Okay, so I think we can go ahead and get started. Welcome, everyone. Thank you so much for joining us. We are here today with the Johns Hopkins Maternal and Child Health Center, India, and this is part of our free online course, The COVID-19 Response in India, Impact on Women and Children's Health and Wellbeing. And so this course is an offering that has been made possible with our partnerships with the NHSRC, the Bloomberg School of Public Health, and the ICMR National Institute of Cholera and Enteric Diseases. Just before we get started with our presentation, we'll have a few really quick course updates. So enrollment does remain open for those of you that may be joining but are not currently participating in the course. So if you would like to enroll and access the rest of the course materials, you are still free and welcome to do so. You can do that by going on our website. I can drop the link in the chat. And enrollment will remain open for the duration of the course, which will be until 30th June. The certificates of completion we have started issuing to eligible learners. So as a friendly reminder, to be eligible for a certificate of completion, you must have completed all of the course module quizzes with an average score of 70%. And so those will not be automatically generated. They will be sent manually in batches. So we'll be sending out the next batch next Monday, May 23rd. And then of course, this is the second in a series of live sessions that we've been offering to really build and expand on the course materials that we don't have in our existing modules. So we're happy to continue offering those. And the next one will be held on Monday, June 6th at 6 p.m. IST. And of course, this course would not be possible without your course faculty. So I am happy to turn it over to them. I am thrilled to announce Dr. Svea Klosser, who is a medical anthropologist. She's associate professor within the Bloomberg School of Public Health in the Department of International Health. And she is also the associate director of education and learning for the Johns Hopkins Maternal and Child Health Center, India. So Dr. Klosser, I'd like to pass it over to you.
Thanks so much, Emily. And I'm thrilled today to introduce MCHI briefly and then introduce David Bishai, our guest speaker. So the Maternal Child Health Center India, or MCHI, is a center at Johns Hopkins inside the Department of International Health in the School of Public Health. And our vision is a world in which every mother and child in India experiences optimal health and well-being. And to that end, we do a lot of things. And one of them is this course. And the goal of the course is in line with our mission to strengthen public health capacity, particularly in maternal and child health. So our speaker today, we are so lucky to have Dr. David Bishai. So Dr. Bishai is a health economist. He was has been a professor for many, many years in the Department of International Health within the Health Systems Program here at Johns Hopkins. And he has a very, very distinguished record of publications, and I encourage you to look them up and take a look at them. But for me, that's not what's most special about Dr. Bishai. In fact, what I think is most incredible about him, even though he's had an incredibly productive and impactful research career, is his impact on the people around him, particularly in terms of encouraging us to think about and be committed to primary health care. So one example of this is his book, Achieving Health for All, which just came out, I think, last year, and won the Sharmanov Prize for contributions to the field of primary health care. But this book is just one piece of how Dr. Bishai has been truly committed to the goals and the ethos of PHC throughout his entire career. One way he's done that is by being a wonderful, thoughtful, supportive mentor to generations of students and junior faculty. And I can say this because I am one of those junior faculty. He is just exceptional in his care and thoughtfulness around students, junior faculty, and encouraging all of us to think about sort of our moral compass and to think about how we can contribute to the goals of PHC. So I'm so pleased to have Dr. Bishai here today.
Thank you, Svea. Thanks for having me today and welcome. I wanted to just share some thoughts about primary health care. I'll share some slides with that too. You should be seeing my slides now. What we'll be doing today is talking about partnerships and calling them Bedrock. Bedrock is what you build structures on. It's foundational. And we'll be illustrating these concepts with case studies from India, from the cases of Jamkhed and Gadchiroli, and showing how what was established 40 years ago in India is so relevant today for the world, and needs to come back and get our attention. If there's one quote that illustrates the bedrock, it's this quote by Indigenous Australian named Lilla Watson, who was visiting. She was a keynote speaker at a meeting in Nairobi, one of these United Nations conferences. Everybody's dressed up in the suit and the tie, and there's live translation. And she looks at them and she says, "If you have come here to help me, you are wasting our time. But if you have come because your liberation is bound up with mine, then let us work together." And I've presented this quote in classes over the years. And students, every year they say, "I don't need liberation. What is Lilla Watson talking about?" So maybe when questions and answers come, and over the course of these slides, we'll understand why everybody needs liberation together, why the world isn't divided up into the saviors and the victims, that this is a mutual project and it's done in partnership. And the version of that comes directly into the words primary health care. I'm going to take you back to the origins of primary health care and help you recover what the word really means. So one of the biggest objectives is that you will develop a complete understanding of the word primary health care. And every time you hear it from now on, you will precede the word with other words: community, engaged, multi-sectoral, population level, PHC. You'll need all of those other words, CMSPL, primary health care, because that's what it was defined as. That's what it still can be and still is. And I want to illustrate the origins of CEMSPL primary health care in India, because that's where some of the foundational work was done. And then you'll see why this true version of primary health care is connected to public health and why it is so relevant to COVID-19. So we're going back to recover what the concept was way back at its origins. And I'm going to show you one of these United Nations rooms with people full of suits back in 1978. This is the meeting room in Almaty, in what was then Soviet Russia, and is now in Kazakhstan. This was the room where the Alma-Ata conference was held in 1978. This green book was the publication that came from this United Nations conference. And their declaration was so important. I'll be showing it to you in just a minute. But one way to talk about the motivation for the conference was a recognition in the 70s that there was inequality in the world. And there was inequality not just between developed and developing, but inside the countries themselves. And for an audience from India, you know exactly what I'm talking about. The within country inequity is, as they said at Alma-Ata, politically, socially, and economically unacceptable. So countries came because they recognized that inside countries, there were inequities and they needed to address them. The lead up to the Alma-Ata meeting in 1978 had a pre-reading. There was a 1975 case study manual that was put together by the WHO. And people going to the conference in 1978 were supposed to read the manual. I wanted to show you the table of contents from this manual. It's still available online, and you can find this book, Health by the People. But they were case studies from, I highlighted them for you, China, Cuba, Jamkhed, Iran, Tanzania, Niger, and other countries. But today we're going to focus on the article by Mabel and Raj Arole, as well as a successor to them, because this work that was done in India led to the thinking of what should be done for the world at the Alma-Ata conference. So when they came to Soviet Russia back in 1978, they first defined what they thought was the word primary healthcare, and they achieved a consensus to focus upstream and on the periphery of their societies. They did not have an implementation plan. All they had going out of the Alma-Ata conference was a set of case studies. So now let me sort of show you what they used in their definition of primary healthcare. There's a lot of words here, and I highlighted in red pieces of the 7 core principles of the Alma-Ata Declaration. This is a direct quote from the document, but I wanted you to see that they say principle number 1, it is related to the economic conditions, sociocultural, and political. Number 2, these 4 words, you'll see them still today: promotive, preventive, curative, and rehabilitative. That primary healthcare has to do all of these. Those 4 words, you'll see them in the definition of UHC, or universal health coverage. We still want to cover everybody, not just with curative, but these other red words: promotive, preventive, and rehabilitative. That goes back to 1978, that it's not just taking care of sick people. The third element of primary healthcare as defined at its foundation shows you that it was so much more than taking care of sick people. The food supply, proper nutrition, water, sanitation, prevention, and the control of locally endemic diseases. That sounds like public health to me. And look at number 4. It is all related sectors. What I said about multi-sectoral, meaning you're going to work in agriculture, animals, food, industry, education, housing. All right, so I hope some of you are into the housing and are architects and home builders. Public works, communications, it is multi-sectoral. They said this in 1978. They wanted to have community self-reliance and individual self-reliance and participation in the planning, organization, operation, and control. They wanted to give power to people in their communities to run their health systems. That's primary healthcare. Integrated, meaning the referral systems at tertiary, secondary, and primary work together. And finally, number 7 is that it's not just going to be doctors, but besides physicians and nurses and midwives, auxiliaries and community workers. So that was all in the definition of PHC back at the beginning. And to summarize it, this graphic might help you see that it's community engaged, multi-sectoral, and population level. I'm just trying to see if I can get rid of my little yellow mark here, but I can't. All right. So going back. Population level, multi-sectoral, and community engaged is what comes in 1978. Well, this did not sit well with the Western powers that be. If you could imagine being the head of the World Bank or the Ford Foundation or even UNICEF, you're not feeling love in 1978. You're hearing about global leaders saying, we want communities themselves to be in charge. More so, the Western global health powers were frightened that they would be asked to pay for all of these bottom-up community engaged housing and agriculture services. And this frightened them. And so the following year, they met in Lake Como in Italy in the Bellagio Center to talk about what to do with this crazy concept of PHC. This is really a counter-revolution. And attending this counter-revolution in Lake Como were the powers, the Rockefeller Foundation, Ford Foundation, World Bank, and UNICEF all go here and they say, we've got to find a way to get back our power as the saviors of the world. And what we want is something that's not primary health care. We're going to put our own adjective, not this community multisectoral. We want to talk about selective primary health care. And a lot of us remember this acronym GOBI FFF. GOBI is the selective, most cost-effective pieces of the health interventions: growth monitoring, oral rehydration, breastfeeding, immunization. F is for food supplementation, female birth spacing, and female education. These are all great programs. And if you look at global health today, there is several programs in maternal and child health programs, selective interventions. And we talk about immunization. Many of us work on selective immunization programs. You just take a piece of the health world and deliver it, and it's very cost effective. So economists like me were brought into global health to take the pieces of selective primary health care and to talk about how we should finance it and just do it to the people in these vertical programs. Take your program and we will help you with whatever disease you've gotten, and using the selective primary healthcare strategy. Very good for donors, very good for the World Bank and foundations to say, we will take this program and we know what it's doing and we can finance it for you. The Bellagio report of 1979 was said to be an interim strategy. They said, we're going to do this selective thing just until the countries are strong enough to build back that PHC thing you were talking about in 1978. We are still deep into this counter-revolution. The powers in health still love the selective programs. And I'd like to go back to 1978 in a way, and go back to before 1978 to Jamkhed, which was the pre-reading, which was the bedrock of Jamkhed. And for those of you who know some of this story, it's review, but for others, this is an Indian contribution to global health that I, as a Westerner, feel a little bit unqualified to deliver. I think if any of you are in Maharashtra, please make the trip to go and visit Jamkhed. It's worth it. The Jamkhed Comprehensive Rural Health Project was founded by Johns Hopkins alumni, Raj and Maybell Arole. They graduated in 1970. In 1970, they wanted to go and focus on building a small hospital surrounded by subcenters, teams of nurses, paramedical workers, sanitation work. They learned this at Johns Hopkins because back in the 70s, Hopkins professors were teaching about a small health district where you would do it this way. This was the Johns Hopkins School of Public Health recipe, where you would do community participation. So they went to Eastern Maharashtra looking for a place to start their lives. Two idealistic Hopkins grads. Here's their picture back in the 70s. So the first place they go in Maharashtra, I hope you can figure out where we are in the map. This is the Indian Ocean, and we've got this small district of Osmanabad here in the middle of Maharashtra, and they go to talk to the mayor of Osmanabad, and they have a meeting with 40 villagers, and they were appalled because none of the villagers would speak at this village meeting. The mayor says, of course they're not speaking. I'm the mayor, and whatever I say, they'll do, and they'll just follow me. Now, if a typical program interventionist, if all I wanted to do was vaccinate the city of Osmanabad, I would say, this is fabulous. I've got the mayor of Osmanabad saying he is going to get it done. I'm in. I'm going to build my program here because I've got a powerful leader who can do anything we want to these people. This could be great. You got political will, the mayor likes you, and he's going to let you vaccinate these people. You can give them growth monitoring, oral rehydration. You can, all of those packages that you get money for are going to happen in Osmanabad. So you would think that Raj and Mabel Aroli are going to be thrilled that the mayor has such absolute control of the people. But that's not what happened. The Arolis moved on. They didn't stay in Osmanabad because they knew they wanted community participation. When they went to Jamkhed, the town meeting was different. The citizens said, look, we want you here. It wasn't just the mayor, it was a bottom-up foundation. So they moved from Osmanabad over here to Jamkhed district here in the middle of Maharashtra. What the people said they wanted most was a dispensary, even though the Arolis were from School of Public Health and they thought, listen, we need clean water, we need sanitation, we want to do nutritional counseling, we want hand washing. They didn't do that. The people said, we want a place to take our sick children to. And so the Arolis listened and they said, okay, look, we're doctors, we will build a dispensary. And by listening to the people, they first started opening a clinic with access to clinical services. And for the very first year, that's all they did. They saw the primary healthcare problems of the people. People came in with sicknesses and were taken care of. The first 1 year into their time in Jamkhed, there was a severe drought. And people said, look, you know, we're glad you're here with a dispensary, but we've got a drought and we need to find a way to get some wells drilled. The Arolis were connected and they could find resources to bring in a drilling company in to drill the wells. They drilled the wells and they were very forward thinking in the location of the wells because they drilled the wells in such a way that people would have more caste mixing. Instead of drilling the wells where the higher caste people were and they could just go out and get the wells in the high caste districts, the wells turned out to be located in the lower caste neighborhoods to help move the people into more social connectedness across caste lines. So that led to a focus on access to water. Soon after, because of the social connections that had been formed, the Arolis started to bring together farmers groups to talk not about health, but about crop yields and fertilizer and green revolution and farming. The male farmers had their groups, and it was natural enough for there to be women's groups to talk about the interests of women's in access to food, access to places to market their handicrafts. And finally, they turn those conversations into, let's talk about primary health care. So they don't start with their agenda of, you know, we want to promote vaccines and nutrition. They start with the people of Jamkhed's agenda, which was water, farm yields, and women's issues, which were related mostly to managing the household. So the partnerships start to form. They had 3 tiers of partnerships. There were those with community control, and they took care of food scarcity, sourcing food and helping staff a community kitchen. When there was water scarcity, the Arolis, using their connections, could bring in geologists from the state and bring in financing for tube wells and local volunteers to keep the water projects working. There was multi-sectoral integration, that there were government programs in the background all around Jamkhed, and they could bring in government VHWs, village health workers, midwives, and nurses, and help to improve the facility services. So this was still going, and that kept on going for 40 years, a multi-sectoral, community participatory, root causes approach to healthcare that was so much more than just here is a dispensary, and it really owed to the long-term vision of Mabel and Gadchiroli. So that was written up. It inspired Alma-Ata. It's still running. You can still visit Jamkhed and see how this can keep going. I want to move on to another case study that ended up in Gadchiroli. I want to start with the very first origins of a realization of Lilla Watson's quote that one's liberation is bound up with others. Here is the city of Kanpur. We're still in Maharashtra, but now we're farther in the east in the forested part of Maharashtra. And there is an agricultural worker named Ajabrao Avante. He's out in Kanpur, India in 1978. It's probably around the same month of September that the Alma-Ata conference is taking place 1,000 miles away. But it's harvest time here in Maharashtra. And Mr. Avante is going to get work as a day laborer. And he's feeding a threshing machine. And obviously, you know, the punchline is that he is injured in his work as a day laborer, and his hand is caught in the threshing machine. So he goes to the doctor. The doctor turns out to be a young Indian doctor, Abhay Bang, and his wife is an obstetrician gynecologist, Dr. Rani Bang. The doctors treat Avante's injury, and they're very altruistic and compassionate people, and they understand that what it means for Mr. Avante to lose his hand would be a loss of livelihood. So because they're so compassionate, they think that one thing to do would be to campaign for Mr. Avante to have workers' compensation and to have his employer give him 3 acres of land. So they start this campaign and they call for all the villagers to come in and talk about their plan to give Mr. Avante some land. But you know, the landowners aren't stupid, and they launch a counter offensive, and there's a few rocks flying around this village assembly, and the doctors are lucky to escape down a dark alley and escape injury themselves. They lost that campaign, and they later went back to ask their friends, you know, what went wrong here? Why we had such a great idea to ask for social justice, and what went wrong? And so one of their neighbors in the town said, listen, the mistake you made is that you came here to serve us as doctors. But while our health problems remain unsolved, you want to act like political leaders, so we were angry. This is their dilemma, that they thought that they were liberators, but they were coming at it from their ideas and not coming as listeners to what the people wanted. So this happens very, early 1978. They're just out of medical school, and they start thinking about this for a while. And Act 2 of this story is that they come to Baltimore. So now it's 1984, 14 years after the Raj and Mabel Arole another Indian couple comes to Johns Hopkins, and they get their master's degrees in 1984, studying with Carl Taylor, who was the former chair of the International Health Department. Carl Taylor he had written vast pieces of the Alma-Ata Declaration as a consultant for WHO. So after they get their MPH, they go back to Maharashtra, and they go to a new city, the city of Gadchiroli, and they start an NGO called SEARCH, Society for Education, Action, and Research in Community Health. Gadchiroli in eastern Maharashtra, 40% tribal, lots of forests, lots of floods. And again, they start with a primary care clinic. And again, they say, we've got to listen. Now, by this time, of course, they'd read the Alma-Ata Declaration and read that what you do is start to listen. This is what they learned the hard way with Mr. Avante. So they start to have village assembly meetings, because that's what you do. It turns out in this part of Maharashtra, It's kind of like Osmanabad. Nobody spoke. They have this meeting and the mayor speaks and nobody else speaks. It's just this culture of this is not how we feel comfortable. So what they did instead was to go out in the evenings, out by bonfires, and just have one-to-one talks with the villagers. What is important to you? What are your health beliefs? Mrs. Bang and Dr. Bang, both of them worked independently. So Dr. Ronnie Bang could have talks with women, and her husband could have talks with more of the farmers and the men. So they asked, what are your health beliefs? What's important to you? They know that they need to have a community health worker program. So they start the Arogya Dutes community health worker program with home visiting for health promotion, and they build in a demographic surveillance of births and deaths and child morbidity. Common feature that you'll see in a lot of primary healthcare programs. Because they spoke to the people at these bonfires and then one-on-one, they were able to have a idea about what was important. And what they learned, the women disclosed a lot of concerns about sexual and reproductive health. They said, our backs hurt, we've got backaches, big health problem for us as farmers. They had fevers and their children had fevers, so malaria went on the list. They talked about alcohol addiction. Alcohol was not in the playbook of global health. I would really doubt that they had took a class in alcohol control during their time at Johns Hopkins in global health. But the people of Maharashtra said, we see families all around that are suffering economic and psychological devastation from alcohol. And then, of course, they had child death problems. And the epidemiology broke down into both neonatal and post-neonatal pneumonia in the child health problems. So the people's agenda was listened to. They're coming together one-on-one to talk to Dr. Bang and Dr. Bang. And what emerges for the doctors is that rather than having deficits of brokenness and disease, they had assets. They had a willingness to volunteer and become community health workers. There was an unenrolled army of people who would help each other if only they could be taught to be community health workers. So this is a picture of Dr. Abi Bang with a machine that I'll talk to you about in a second. He decided that because childhood pneumonia was such an important issue, he would train the community health workers in identifying cases and starting the first dose of antibiotics in the home and avoiding this long journey to receive the first dose of antibiotics. As many of the physicians in the audience know, time is super important, and the shorter the duration to the first dose, the better the outcome. And then after the CHW gave the first dose in the home, there would be a referral to hospital depending on the symptoms. So what Dr. Bang is holding up, if you take a look at it, it is an abacus to count and an hourglass to count time. What he found with the villagers is that they didn't have watches and they had trouble counting respirations. So by using this machine, you would turn it over, it would start to count a minute, and you would count the child's respirations to see if they were breathing too rapidly. And if you breathing so rapidly that they got to a red bead, then they definitely had tachypnea and qualified to as one of the diagnostic criteria of pneumonia. So this was an appropriate technology that was used to help the CHWs after they were trained in early identification of pneumonia. The pneumonia home treatment project was not just implemented, it was implemented in the context of a study design with a a controlled group, or these days it would be called a step wedge, with a delayed treatment group, so they could be compared to conventional treatment. And this was published in the Lancet, showing a mortality reduction for the children that received the treatment with the CHWs. So they used both their local resources as well as the tools that one learns in a modern school of public health to say this is evidence-based now, and it could be later scaled up. Their neonatal health project was also to identify septic newborns, as well as to do primary prevention of hypothermia and sepsis, and to promote breastfeeding. So the neonatal health project did both primary prevention and also how do we identify a septic newborn? How do we give the first dose of antibiotics in the home, followed by referral? So these were subjected to trials, published in the Lancet, and they scaled up. Now, ordinarily, this would be the extent of it, but they listened to what was said in Gadchiroli, and the people said, alcohol is a problem for us. In this setting, the doctors, Ronnie and Abi Bang, said, look, we're doctors. We're probably not going to be the social leaders on this, but we can be conveners and facilitators. So because they had social connections, they could help bring groups together. And in Gadchiroli, a prohibition society, a group of like-minded political advocates formed, led by other leaders, calling themselves the Darumukti Sangathana, women and youth and local sarpanches, the local mayors in 150 villages signed on to this, and they passed local ordinances that prohibited the use of alcohol. And the Gadchiroli district went dry in 1993. It's still dry. Other districts around have gone dry, and then there was a counter revolution that pushed back alcohol. But around Maharashtra, you'll see dry districts forming based on these social movements. The Bang's NGO said, look, if we're gonna go dry, we're gonna need some alcohol rehab and detox camps. And so they turned their medical resources into providing supportive care for those who needed help with alcohol addiction services. So the three-way partnerships that we see here in Gadchiroli, I wanna talk about the three parts of these partnerships. The three parts were the community members, the political leaders, the sarpanches, and technical experts like Dr. Bang and like Dr. Arolis. They always came together with the three parts in these three-way partnerships. And I want you to think about what happens when you have C and P and T that's better than with just any two parts. If you have just the community leader and the political leader, you have populism without science. You have what we see around the world where people say, I can look it up on the internet and I don't need a technical expert to help with the evidence. And you'll see a lot of communities just be way off on a tangent where they're doing things that are not supported by science. If you have the community and the technical expert, but you don't have the people, there's no local accountability, and the people are not engaged and they feel a lack of trust. No one listened to them. They were not feeling like their best interests are being taken into account. And if you just have the political leader and the technical expert and the community, I'm sorry, the C and the T is without the political leader. So you don't have the resources and the money to keep it going and sustainable. Now, it's difficult to pull off C and P and T, but this is probably one of our best ways to build trust, to have all three come together and try to avoid the pitfalls of one taking over the leadership and taking over the power and running the show. So the Gadchiroli ongoing legacy I think we can learn is, like a lot of these best case scenarios of primary health care, that the program doesn't see the community as full of deficits to be solved. They see the community as assets to be convened and to be made powerful. And the community partners participate in being the assets and being the solutions. The mutual liberation, I think you can see, I'll make it more obvious, is that Dr. Bong, early in his life, as the doctor for Mr. Avante with the amputated arm, he needed liberation. He wanted to realize goals in social justice, and he couldn't do them. He was blocked. Until he learned to listen, he himself became liberated by listening to the people of Maharashtra. So he himself was found the assets of reaching these partnerships. And so we ourselves in our profession in global health find that we are liberated too as we come to form partnerships with the people in the communities. A few minutes to bring this into the 2020 decade, COVID-19. I want to remind you about the essential public health functions. What does public health have to do? It has to do these 10 essential functions that are organized into assessing the health of a population, monitoring health status, and diagnosing and investigating health problems. After monitoring and assessing, we form policy development, but it's done participatorily. It's done with the community, informing and educating people about their health issues, mobilizing community partnerships, and developing policies and plans with the people in the community to produce their health efforts. And the last 5 essential public health functions enforce laws, they link people to services, they assure a competent workforce, evaluate the consequences of our actions, and then commit to future research. So if you haven't seen this list of 10 essential public health functions before, write down the words essential public health functions, because this is part of what we do to solve COVID and to solve every single public health problem. So these essential public health functions come from 3-way partnerships, and each of the 3 partners established in primary healthcare has a role in the public health functions. Remember, these are classified under assessment, policy development, and assurance. The 3 partners are necessary for an unbiased assessment, that we want to know that we have the community involved, the politicians, and the technical experts to assess our health problems. In developing policy development, the 3 partners are necessary to bring in the context as well as the evidence to get the best policies. And then once we are assuring solutions to public health problems, we need partnerships because there are multiple solutions for complex problems. And it's not going to be one single solver of problems. It's going to be multiple sectors contributing. I hope you're thinking about COVID-19. COVID-19 has multiple sectors involved in its solution. So the application to COVID-19, of course we need cutting edge bench science. We needed mRNA vaccines and adjuvant vaccines. We needed science about masking. We didn't have it in early 2020. We need to know what the evidence is around testing and tracking and quarantining. We need to understand the values of the communities that affect whether or not we can do these policies. So we need platforms for trusted communications. How do we have conversations where people feel free to express their doubts, express their questions? If we had these platforms, we would also have platforms to deliver other interventions and other commodities. So the COVID-19 platform is also a platform for so many other solutions to so many other problems. This allows us to work on what are called syndemics, where a disease is facilitated by a social set of conditions that works in part to help the disease spread further. Syndemics like poverty and racism help spread diseases like COVID-19, obesity, and violence. I want to talk about why this is so hard, why things like the counter-revolution of Bellagio in 1979 took place, why we are still today not getting it, and why primary healthcare itself, why the word primary healthcare so often is interpreted by the ears as, oh, primary healthcare, that is primary care. I have to take care of sick people. That is only a small piece of primary healthcare. That comes from ego and ethics. This saviorism of I have to help them, I am good and they need me. It's a lot of what attracts people like me and my colleagues into public health. We want to go into this business to become agents of human betterment. And we are looking for liberation, but the ego gets in the way. And the ego wants us to say, I discovered, I delivered, I raised funds, I built, I persuaded, I saved them. And so we have incentives in our lives to seek the funding and the fame and the publications to build our egos as the saviors of the world. And I mean, I just keep laughing every time I see the Johns Hopkins logo, saving lives, millions at a time. Talk about ego. It's on the door of our school. So there's a slippery slope. Once we get into this space, we see the world is full of deficit. They needed saving. They lack something. Their agency is diminished. I must save them. And there come the ethics, right? So the principle of autonomy. People should be able to make their own decisions. And the principle of beneficence. That's a problem because, you know, the crowds are not always so wise. If you just give full autonomy to people who don't know what creates disease, crowd wisdom isn't really that wise. And we need a check on ignorance and the base instincts of crowds who say, you know, drinking bleach. Our president of the United States thought that drinking bleach was a good idea. That's not wise. So we do want to respect autonomy, but there's a need to have a conversation with science as well. So there are heterogeneous visions. When communities come together, it's not always a fairy tale. People do disagree and there is violence and hatred, but disagreements should be resolved through a well-informed and citizen who's come together in this partnership as a forum for deliberation, as opposed to philanthropies having an arms race to try to save them. So what we see today, this race or this duality between the bottom-up world of Alma-Ata in 1978 and primary healthcare said bottom-up, community-centered, mobilize people, create partnerships to create solidarity, have the community be assets. This works, it transforms places, we should keep this up. The top-down isn't bad. This isn't good versus evil. The top-down works too. It's mission-centered. You've got a commodity, you need to give it to people. You need to give them vitamin A and vaccines and IUDs. And if you want to make a partner, the partner is a servant. The partner is partnering to get the product out, not to win hearts and minds. You get external funding and you deliver your commodity and you do save lives. So although they are dualistic, they both work. I do want to say that even though they both work, top down gets the money and top down has crowded out bottom up. The funds from our ministries of health, our local health departments, the big multilateral agencies, the World Bank, their money is going into top down and we are truly crowding out the bottom up. The fact that I have to go back into history to tell you about Gadchiroli and Jamkhed and why we are not surrounded by Jamkheds and Gadchirolis tells you that even though bottom up works, it doesn't attract attention and dollars. So how to do it? The steps in top down, I think you already know. You look in the Lancet, you find a great technology, you deliver it, you raise money, we know how to do that. But the steps in bottom up get lost. You have to join in solidarity with people who want a better life. You have to give up your ego and listen, convene, build trust, identify strengths, and prioritize. This public health technology, assessing and developing policies and assuring solutions. This is the true old-fashioned public health. You need to develop these three-way partnerships like we saw in Gadchiroli. The three partners, ordinary community members, political leaders, and technical experts. In balance, those three partners have to come together, and what they will do when they partner needs to go right. Rather than supplication and domination and grievances, the community just telling the politician, you failed me, you need to give me more resources. Instead, what could go right and what went right in the hands of Dr. Bang and Dr. Gadchiroli was voice and empowerment and accountability and shared responsibility. This can be done. We've been trying to teach that in public health for over 40 years, but we're also not getting through a lot because of this top-down mode of public health. So let me summarize what we've gone through today. Partnerships are necessary. They've been necessary, and they are an important part of the true definition of primary health care. Because the facts and the science is not enough, we need the experts at local context, which are the people themselves. The three-way partnership insists that the motivated citizens join with the politicians and the technical expert. It is absolutely not simple. These three groups don't have equal power, and they don't necessarily feel easy about working together. But this three-way partnership can be applied to every single public health problem, as well as COVID-19, and there are obstacles to it: ego, saviorism, distrust. If you don't have all three, you'll have the pitfalls of the two-way partnerships. But I wanted us to spend the rest of this session talking about how we can develop these core skills in partnership construction and maintenance. I wanted to thank you and take your questions.
Thank you so much, Dr. Bishai. Go ahead, Svea. Go ahead,
Anita.
No, I just wanted to see if there are any questions from the audience or comments. This has been such an incredibly thought-provoking session. And so these deep, lofty ideas are, sometimes can be challenging to internalize. We are really grateful to you, David, for talking to us about so many different ideas. And you mentioned the Alma-Ata Declaration in 1978 and the multi-sectoral approach. It's striking how similar they are to the Sustainable Developmental Goals developed almost 4 decades later. So there's a question from Preetika. Go ahead, Preetika.
Yeah, thank you, Dr. Bishai. This was really enlightening to hear about the journey for both the Bangs and the Enroll. I think my question is sort of in the context of COVID, which has been a global pandemic, rapidly spreading infectious disease. Some of these community outreach approaches often involve, social gatherings, as you said, people were hesitant to talk. So, they used approaches of bonfires and things like that. And I know social media is a huge way of reaching these populations, but I'm just wondering, in the context of COVID, what if there are approaches that have been useful in reaching out to the community that, some examples of those.
Thanks, Preetika. That's a great question. And maybe for those in the audience, you've seen some of these local examples. What we've seen, and I think Svea has been studying them, are these adaptations of the community health worker army to having these conversations in a COVID safe way. Where there is digital platforms like Zoom, I was working in primary health care, having vaccine questions and answer sessions. But we do know that places that had large CHW workforces use the CHWs to help get the word out. And I'll turn it over to others in the audience and in the room who know these stories.
Anyone in the audience who's seen how this has worked successfully at the ground level, we'd love to hear from you. I do think, David, the community health workers, certainly the ASHA and Anganwadi programs, have been critical, of course, in India. Oh, yeah, Shalini.
So I don't have anything to comment, but I was just reflecting on Dr. Bishai's, I'm stuck with the idea of mutual liberalism and, shared responsibility. My thoughts keep on going to the fact that, of course, we presented here about Jamkhed and Gadchiroli. They have been the immense success stories, and there are many more. We have Swami Vivekananda Youth Movement. We have Jan Swasayog in Chhattisgarh, but all these are case studies which are limited to certain pockets. But when we talk about scale, Dr. Bishai, India is moving towards this reform of comprehensive primary health care. And, when we have heroes like Dr. Bang or Dr. Arole, or so many of them, it takes a lot of inherent quality to understand the community. But what inputs can we give to a nurse, let's say, who has been just positioned to bring about a reform which Dr. Arole and Dr. Bang led to for a 5,000 population that they have to cater to in their own service area? How do we inculcate these qualities in these young nurses, young doctors from the public sector who are expected to deliver a likes program like Dr. Bang and Dr. Arole? I mean, I'm really stuck at this question, and I don't know what the answer is when we talk about scale. I know these things are so complex, it takes time. But what advice would you give?
I don't have much time, but one of the things that we know worked well for the vertical programs was quantitation of the deliverables. If you had a BedNet program, you have to count how many BedNets you gave out in order to deliver the contract. What I'm asking for then is to quantify the convening and the voice and the listening. And it's doable. It sounds crazy. It is so doable to measure listening and contact, to have the nurse and the community health worker give evidence of having listened, to have, if you're having a community meeting or a bonfire talk, to count it, and then to be held accountable for that. If the system counts it and measures it, then it does it. And so rather than saying, okay, we just got to count the bed nets, why can't we count the comprehensive PHC and measure it? And maybe I'm too much of an economist, but I know that countable incentives drove the vertical programs, and they need to be used to drive the horizontal.
Thank you, Dr. Bishai.
I think we're at time, and I think there are some questions and comments from the audience. What we'll do is we'll record these comments and take it on the discussion forum, perhaps, since we're just about to close. What do you think, Svea?
That sounds great. We'll take these comments and bring them back to the course in our discussion forum. And of course, if you haven't yet enrolled, we encourage you to. It's free. And many experts from India on that course talking in more depth about some of these issues. But thank you so much, Dr. Bishai, for your time today. And thanks to all of you for spending your evening here with us. Much appreciate it. And we look forward to seeing you at our next live talk.
Absolutely. And Emily has posted the link in the chat box. Just want to quickly thank Dr. Bishai once again, and it goes back to what you started off with your talk and ended with about talking about this is a mutual project, and the world is not divided into the saviors and those waiting to be saved. And sort of goes back to the age-old concept that is outlined in the Upanishads in India, which says Vasudhaiva Kutumbakam, which is the whole world is a single family. And this is a bedrock, the bedrock in which primary healthcare is based. We talk about equity. We also need to act on this. One way is to remove our egos from our actions, like you beautifully put, Dr. Bishai. And I'm sure all of you will have your own take-home messages from this talk. So I encourage you all to think about these concepts and especially how they can be incorporated into our daily lives and work practices. So thank you all very, very much. And thanks, David, once again. Thank you, Emily, and thanks to the entire team of the Maternal Child Health Center.
Thank you so much, everyone.
Bye-bye.
Bye.